Good morning. It's a great pleasure and honour for me as a patient to speak at this year's Vascular Society annual scientific meeting. My declarations are that I am an aortic dissection survivor. I'm chair of the National Patient Charity for Aortic Dissection, and I'm a PPV partner on the NHS England Vascular CRG. I've been asked to speak this morning to the question, do current aortic dissection pathways work for patients? And the short answer is, no, they don't. Now you'll need me to explain that, because as my good friend and your incoming president, Rachel Bell, said to me with characteristic Yorkshire bluntness when we first met a few years ago, well, Gareth, you're alive, aren't you? Well, Rachel, I am indeed alive, and not only that, my life was saved by two brilliant vascular surgeons. On the right is Sandip Sarkar, who was the on-call consultant vascular surgeon on the night I arrived in an ambulance at the Royal London Hospital. He quickly diagnosed my acute type B dissection, sent me over to cardiothoracics, who repaired my descending thoracic aorta, and then later I came back and Paul Flora and Sandip together did an equally challenging procedure to repair my infrarenal aorta. So I owe my life to vascular surgery. But that's not the whole story. One data point does not a conclusion make. As chair of the National Patient Charity, it is my privilege, but rather sad duty, to lead at our annual conference the In Memoriam session, when we remember those who have died of aortic dissection. This is the list of names that I read out on the 31st of October at BMA House. Most of these people were younger when they died than I am today. There are 3 teenagers on this list. The names in yellow are the friends we've lost within the last year to aortic dissection. And many of these people didn't die during surgery or as a result of complications. They died because they couldn't access the kind of specialist care that I was fortunate enough to receive. Neville Bowman died of an acute type B dissection in Watford General, while the ED frantically rang around trying to find someone to accept him for treatment. My father, Harold Owens, had exactly the same type B dissection due to Marfan syndrome that I suffered at the same age. And the difference between us is that I was able to access specialist care with an effective multidisciplinary team at a specialist aortic centre. Many people are losing their lives to this disease unnecessarily, because we need to improve the aortic dissection pathway. And I and the National Patient Charity will not rest until everyone in this country who has an aortic dissection can access the same high standard of care and outcome that I was fortunate enough to receive. So my good fortune was to experience the acute aortic dissection happy path, a known genetic risk which triggered a rapid CT scan and diagnosis in the ED, a specialist multidisciplinary team at an aortic centre who agreed the right cardiothoracic and vascular surgical strategy to achieve a staged replacement of my aortic tree, and first-class monitoring and surveillance and follow-up while I recovered. Our challenge, ladies and gentlemen, is to deliver the happy path consistently, regardless of where the patient presents, of what time of day or night it is, of how far they are from a specialist centre. Everyone deserves fair access to the best care that we know how to deliver. The first piece of the pathway that we need to improve is diagnosis and transfer. And you as vascular surgeons have a role to play in that. In 2018, we launched the Think Aorta campaign. We published a set of free resources that led to the Royal College of Emergency Medicine and the Royal College of Radiologists publishing their first ever joint guidance on how to diagnose aortic dissection in the ED. And what I'd like you to do as vascular surgeons working in vascular centres is to promulgate this to your referring hospitals. Because if it comes from you, it has great credibility. We have plenty of free Think Aorta resources that you can use to do that. You just need to get in touch. But we need to push this message that this is a time-critical, life-threatening diagnosis, and we need to highlight where these patients should be referred in a timely manner. I was the patient representative on the team that developed the NHS Acute Aortic Dissection Toolkit, which is now being implemented with the Society's support. What we want from this is patients to access specialist care from a specialist team in a specialist centre 100% of the time in every region across the UK. If we achieve that, we will reduce the big 5 risks: mortality, stroke, paraplegia, infection and re-intervention. Professor Rob Sayers and Rachel Bell and I have worked very hard to get vascular and type V dissection included in the scope of this toolkit. And now we're looking to you to engage with your cardiac colleagues in the regions and to implement the toolkit principles to improve care for patients. Improvements in our ability to treat aortic dissection medically and surgically over the last 20 years have created a growing cohort of survivors. And what we now need to do is work out how best to deliver lifelong follow-up care for these patients. The things patients tell us that they need and which are very patchily provided are cardiac rehabilitation, psychological support, referrals to genetics for themselves and for family members, and optimised surveillance and monitoring for future signs of the disease and of their family in order to prevent aortic dissection. One of the ways in which we as the National Patient Charity can help you improve long-term follow-up care for your patients is through Aortic Dissection, the Patient Guide. This is a new publication. It's a 96-page handbook written by patients, for patients, and it's been through a clinical review and been endorsed by the Vascular Society and SCTS. Almost all of the cardiac aortic centres are now giving this guide to their aortic dissection patients prior to discharge, and we would like vascular aortic centres to do the same, so that every aortic dissection patient in the UK gets a copy before they leave hospital. It's completely free. You can go to our website on the bottom right hand corner. You'll find an order form, order as many as you want, and we will ship them to your unit within 2 to 3 weeks so that you can hand them out to your patients. If we're serious about improving the aortic dissection patient pathway, then we need to keep score. After a number of years, the cardiac surgeons are now able to give me a national picture of surgery for type A aortic dissection, and remarkably, cases are on the rise, and between 2015 and 2018 they rose by 29% on the back of a wave of increased awareness and campaigns like Think Aorta. Nobody can tell me what the national picture is for type B dissection, and frankly, as a type B dissection survivor, I feel like we're a poor relation. We need to get the data so that we can keep score and know that the improvements we are making are delivering real benefit. Finally, ladies and gentlemen, I'll tell you what I told the cardiac surgeons when I spoke at their annual conference, that this disease needs a genuine multidisciplinary team effort. There's no I in aorta. When my aorta dissected, it went from cardiac surgeon's territory to vascular surgeon's territory before I hit the floor. So I'd like to encourage you to work across your professional boundaries as we seek to improve this pathway and deliver one that works for aortic dissection patients. Thank you for your attention. It's been a privilege to speak to you today, and I hope that next year I can join you in person. Thank you.